Really appreciate the info and the beautiful images. We're going to leave questions till the end. I'm taking notes of them. We'll move next to our speaker in the sake of time, Dr. Majumder from Mayo Clinic, who will talk to us about pancreas cysts. Shounak, the floor is yours.
All right, thanks a lot, Maisam. Really appreciate the invitation to come speak to this audience. And it's always easy to talk about pancreas cysts after a radiologist because the whole audience is very familiar with looking at images. So through the course of this talk, I'll share with you some more images. My only disclosure other than my love for the pancreas is as a co-inventor of intellectual property with Mayo Exact Sciences collaboration. The objectives of my talk over the next 20 minutes or so would be to share with you what we know about the epidemiology of pancreas cysts, what is the risk of pancreatic cancer associated with these lesions. I'll go through the classification and some salient diagnostic features of each of these different types of cysts, and then spend the last few minutes discussing management of IPMNs, which are the types of cysts that we have to encounter in our clinical practice most commonly. So starting off with what we know about epidemiology. Pancreatic cystic lesions are commonly identified incidentally, so the patient does not have any symptoms. And a lot of investigators have attributed the increased use of cross-sectional imaging as a reason as to why we are seeing more and more of these lesions. If you look at the literature describing the prevalence, there are numbers ranging anywhere from 2 to 40%. The MRI studies report a higher prevalence compared to CT. We really don't have true population estimates. Most of the studies are in hospitalized patients and in institutional cohorts. The prevalence of incidentally detected pancreatic cysts does increase with age. In this paper published in the Red Journal in 2010, you can see with every decade increase in age, the percentage prevalence of incidentally detected cysts goes up. And oftentimes we'll see that when the study radiologists review these scans, they identify more cysts than what's reported in clinical practice. The question that comes up frequently is what's the risk of pancreatic cancer associated with cystic disease of the pancreas? It's only a subset of pancreatic cysts that are precancerous, and the majority of these incidentally detected cysts will cause no harm. The challenge in our practice is to identify and manage the small subset of cysts that have malignant potential. Another point that's important to recognize is that the majority of patients who undergo a surgical resection for a pancreas cyst will not be found to harbor high-grade dysplasia or cancer. And I'll come back to this at a later point in my presentation again. There's a very interesting study done by Vichen Wu and his group from California that show that the majority of deaths in patients with a pancreatic cyst are actually unrelated to pancreatic cancer. So they looked at nearly 2,000 patients, reported over 400 deaths, of which only 43 were related to pancreatic cancer. And it is our experience that patients with multiple medical comorbidities and a low-risk cyst, they're significantly more likely to experience a non-pancreas cancer mortality than die from pancreatic cancer. We looked at the family history of pancreas cancer, as that is a known risk factor. And in a Mayo study that was led by Suresh Chari, we reported that the presence of one family member, a first-degree relative, does not increase the risk of pancreatic cancer in patients with pancreas cysts. So moving on to the classification of cysts, very broadly, we can think of cysts as benign or malignant or pre-malignant. Some of the common benign cysts that we see include retention cysts, lymphoepithelial cysts, the inflammatory pseudocysts that were referred to by the previous speaker, and serous cystadenoma. For precancerous and cancerous cysts, you can broadly divide them into mucin-producing cysts and other neoplastic cysts. The other neoplastic cysts include cystic neuroendocrine tumor, solid pseudopapillary neoplasms, and sometimes a cystic degeneration of ductal adenocarcinoma. For mucin-producing cysts, they're broadly classified as IPMNs, or intraductal papillary mucinous neoplasms, and mucinous cystic neoplasm. And IPMNs can in turn again be subclassified as branch duct, main duct, or mixed. And this is a broad scheme of the classification. What I'll do over the next few slides is review some of the salient diagnostic features of each of these different kinds of cysts. So starting off with pseudocysts, as you heard in Dr. Turkey's talk, this often follows an episode of pancreatitis. So a clinical history of pancreatitis is often a good clue when you're trying to figure out whether a cyst is a pseudocyst or something else. And oftentimes we'll see imaging features of chronic pancreatitis in the background. So if you look at the image here, we see this large cystic collection. But if you turn your attention to the pancreas, you'll see there is evidence of pancreatic ductal calcification and a dilated duct, which is radiologically suggestive of chronic pancreatitis. Now, this won't be present in all cases, but when present, it's very helpful. It's important to remember that a mucinous cyst or a precancerous cyst can also present with pancreatitis. So the history of pancreatitis does not automatically make a cystic lesion a pseudocyst. And when faced with that situation, we'll often ask this question in Pancreas Clinic as to what came first, and whether the cyst was there before the episode of pancreatitis or after. And oftentimes reviewing previous imaging from the patient can serve as a very helpful diagnostic tool. When we look at cyst fluid analysis in pseudocysts, they typically have a low CEA and an elevated amylase level. A low amylase level is actually very useful as negative predictive value for pseudocysts. And the management in most cases when symptomatic is endoscopic drainage. And as a part of that management, we assess for a disconnected duct. You saw some MRCP images in the previous talk. This is a risk factor for recurrence, so should be recognized at the time of index endoscopic intervention. The next benign cyst type that I'll share with you is a serous cystadenoma. So radiologically, the appearance of a serous cystadenoma can sometimes be fairly classic. You'll see multiple thin-walled cysts with what is a buzzword for board exams is the honeycomb appearance and the central scar. So you can see that this is a representative CT image of a serous cystadenoma. Occasionally, these lesions will be unilocular, also described as oligocystic serous cystadenomas, and then it becomes really difficult to differentiate that from some other cystic neoplasms. On EUS, the cyst fluid CEA in serous cystadenoma is very low. Histology will often show a PAS-positive cuboidal epithelium. Here's a resected pancreas from a patient with a serous cystadenoma. You can see the cystic lesion there. And in asymptomatic patients with a confirmed diagnosis, there is no surveillance that's indicated as these are benign lesions. The indications for resection include symptoms such as biliary obstruction. Sometimes these lesions can be really large and cause symptomatic abdominal pain just by virtue of their large size. The next category, moving on to neoplastic cysts, is a solid pseudopapillary neoplasm. You saw some images of this in the previous talk as well. This is a relatively rare cystic lesion and typically occurs in young women. The radiologic presentation is that of a solid cystic lesion. And these are indolent, slow-growing lesions. Here's a axial and a coronal image showing the fairly large cystic lesion in the head of the pancreas, solid cystic lesion. Now, they do have what is described as intermediate malignant potential. About 10 to 20% of them can be malignant. There are reports of metastatic disease. Histologically, it's characterized by a somatic beta-catenin mutation. And because of the malignant potential, surgical resection is typically recommended. Moving on to cystic neuroendocrine tumors, the diagnostic clue on imaging here is often peripheral contrast enhancement. So if you see the top panel of the images, here you can see the wall of the cystic lesion enhances, and that's often a fairly classic radiologic finding for a cystic neuroendocrine tumor. The cyst fluid CEA in these patients is again low, and we now have PET dotatate imaging that can demonstrate intense uptake in the cystic lesion compared to the surrounding parenchyma. So you can see here, there's intense uptake in the cystic lesion, indicating it's a cystic neuroendocrine tumor. Now, interestingly, compared to solid pancreatic neuroendocrine tumors, these are less commonly associated with lymph node and liver mets. The management of cystic neuroendocrine tumor actually remains somewhat uncertain because there's limited data, specifically in these patients. But what we know from solid neuroendocrine tumors is that functional lesions should be resected. In non-functioning neuroendocrine tumors, the management is really based on size. There's consensus that if the lesion is small, less than 1 centimeter, they can be observed with clinical surveillance. Above 2 centimeters, usually we're leaning towards surgical resection. And between 1 and 2 centimeters, the decision to either do surgery or do surveillance is individualized. Now moving on to mucinous neoplasms. Mucinous cystic neoplasms are typically unilocular, solitary cysts in the body and the tail of the pancreas, and the classic description in a board question will be unilocular solitary cyst in the pancreatic tail in a middle-aged female. And that's the classic demographic presentation of this disease. Cyst fluid CEA is elevated, and histologically this is characterized by ovarian stroma. The management of mucinous cystic neoplasms, vast majority undergo surgical resection because of malignant potential, young age at presentation, and location in the tail. I think one of you might have your speaker on unmute. And then for some smaller cysts that are located in the body or the head, in asymptomatic older individuals, may be managed with surveillance. Intraductal papillary mucinous neoplasms are the other category of mucinous cysts. And on cross-sectional imaging, these lesions are often multifocal. As you can see here, this is an MRCP image. You can actually see numerous small and large cystic lesions all over the pancreas in this particular individual. One of the diagnostic clues is that the cyst communicates with the main pancreatic duct. On EUS, in main duct disease, you can see fish mouth appearance and occasionally intraductal mucin within the main pancreatic duct. And cyst fluid analysis demonstrates an elevated CEA. There are other ancillary signs that can be helpful in making the diagnosis, such as the string sign and positive mucin stain. And more recently, we have molecular markers such as cyst fluid GNAS that can help make this diagnosis as well. What is an important thing to appreciate clinically is that cyst fluid cytology has very poor sensitivity for detecting high-grade dysplasia or cancer. It has high specificity, so a positive result indicates something concerning. However, negative cyst fluid cytology is really not very helpful in these patients. So spending a little bit more time on IPMN classification, I had mentioned they are branch duct, main duct, or mixed lesions. So here you see image of a branch duct IPMN, and on this MRCP image, there are cysts of different sizes across the head, body, and tail of the pancreas. And that's common in these patients. These lesions are often multifocal. And if you look carefully at the blue arrow I've tried to point out there, is that the MRCP often helps us identify a communication with the main pancreatic duct, which favors this diagnosis. In main duct IPMN, it's important to recognize that these patients are at a higher risk of malignancy. So any features of main duct involvement should be a cause for increased attention. And some imaging clues that are helpful in identifying main duct involvement include a dilated main pancreatic duct, the presence of intraductal mucin, thickened main pancreatic duct wall, and the presence of neural nodules. So here you can see, indicated by the blue arrow, is main duct dilation. Right adjacent to it, there is a branch duct lesion. So this is an example of a mixed main duct and branch duct IPMN. This is the pancreatic resection specimen. And you can see that this here indicates that there is a branch duct, and right adjacent to it, there is dilation of the main duct. In this particular case, both involved with low-grade dysplasia. So moving on to guidelines for management, and I have listed here the different guidelines that are available to guide management of pancreatic cysts. And there are several guidelines that have been formed to assist in clinical decision-making. There are subtle differences in between all of these different individual guidelines that often make clinical decision-making challenging in these patients. But one common theme is that the aim is to identify cysts that are at high risk of either harboring prevalent cancer or future development of high-grade dysplasia and cancer. And the questions that you're asked to answer as a clinician is, should we opt for surgery versus surveillance? And if we opt for surveillance, what interval and what imaging modality to use? So in the next few slides, I'll share with you the Fukuoka consensus guidelines, which is the guidelines that specifically addresses IPMNs, where this question of surgery versus surveillance comes up most frequently in our clinical practice. So these consensus guidelines were last published in 2017. And the first question that is asked is, are there any high-risk stigmata? And the high-risk stigmata include jaundice, the presence of an enhancing mural nodule, and main duct dilation more than 10 millimeters. If any of these are present in an individual, then the recommendation is to consider surgery if clinically appropriate. What do you do if these features are not present? You look for additional worrisome features, and there's actually a long list of worrisome features that includes clinical pancreatitis, certain imaging features for the cyst itself, changes in the pancreatic duct, and presence of lymphadenopathy. Some features that have been added in the most recent revised versions of this guideline is an increased level of CA19-9 and growth of the cyst over time. Now, if worrisome features are present, the Fukuoka guidelines suggest we further evaluate the cyst with an endoscopic ultrasound. Again, we are looking for a mural nodule, looking for anything that's suspicious for main duct involvement or a positive cytology. If those are present, then you go back to considering surgery. And if those are absent, then the guidance is to use the size of the largest cyst to determine how frequently you would need to do surveillance imaging. Now, I've summarized this in the table here, again, bringing your attention that it's a constellation of clinical features, imaging, and biomarkers that help us determine if there are high risk or worrisome features. And what we do in terms of surgery versus surveillance and how frequently we do surveillance depends on these findings. Now, despite what we have in clinical practice right now, the sensitivity and specificity of most of these guidelines in determining who has high-grade dysplasia or cancer or will go on to develop it is usually in the 60 to 70% range. And that is important when making clinical decisions, is understanding that none of these guidelines are perfect at determining the outcome of interest. That has led to a lot of interest in the field in the last few years. That is focusing on molecular detection of advanced neoplasia in these lesions. There are two approaches that are broadly being used. One is, you see in the top panel here, this is a FNA needle. This is an endoscopic ultrasound image where we can puncture the cyst and obtain a diagnostic sample of cyst fluid. There are genetic markers, as I indicated, as well as our team here at Mayo Clinic has worked on methylated DNA markers, looking at cyst fluid analysis for predicting advanced neoplasia. The other biospecimen that has been looked at as a potential source for molecular markers is pancreatic juice. This is an endoscopic image of the small bowel. What you see here, the white structure, is a suction catheter. And the lumen here is actually filled with pancreatic juice. This is only possible with the injection of secretin. You just heard from Dr. Turkis the applications of secretin in MRI imaging. Secretin really increases pancreatic juice secretion. It allows us to collect this juice from the duodenum without cannulating the pancreatic duct and exposing the patient to risk of pancreatitis. Now, either cyst fluid or pancreatic juice can serve as a biospecimen for then downstream molecular analysis, and that can help us determine if the highest grade of dysplasia is low grade or high grade, and the presence of high grade dysplasia and cancer would then help us select patients that would benefit from surgical resection. In addition to molecular markers, the other area that has really advanced in leaps and bounds in the last few years is imaging. And imaging advancements have both used advances in EUS imaging by a technique called confocal endomicroscopy. It actually allows for a very close evaluation of the lining epithelium of the cyst, as well as there are several technologies of artificial intelligence-based imaging that are at a fairly nascent stage, but are very exciting future applications. With that, I'd like to summarize with a clinical approach that you can use in your clinical practice. When faced with a patient with a pancreatic cyst, some of the questions that are going through my mind are, is this incidental or symptomatic? Because if it's symptomatic, your treatment decisions might have to depend on symptoms and not on the cyst itself. The second question you're asking yourself is this a benign or a neoplastic cyst? And the determination there is no one test that will give you the answer. So it's going to be a combination of the clinical features, imaging appearance, and sometimes cyst fluid analysis that I summarized in my previous slides. The next question is, if it is a presumed IPMN, are there any high risk or worrisome features that are present? Whether we do surgical resection or clinical follow-up with imaging surveillance is the question that comes next. And that's informed by whether the high risk or worrisome features are present or not. As I mentioned previously, none of these guidelines are 100% perfect. So it's very important to engage your patient in a shared decision-making model when making that decision. And in patients who undergo a partial pancreatectomy for an IPMN, it is important to recognize that post-operative surveillance is recommended. There is a field effect of neoplasia in these patients. There are several studies that have demonstrated that these patients are at a higher risk of developing pancreatic cancer or recurrent IPMN in the remnant gland. And especially if the resected pancreas demonstrates any evidence of advanced neoplasia in the form of high-grade dysplasia or cancer, this post-operative surveillance becomes even more important. So to summarize, I would say that incidentally detected pancreatic cysts are common and the prevalence increases with age. A subset of pancreatic cysts are neoplastic. Others are benign or inflammatory. And you have to use your clinical judgment and radiologic features and cyst fluid analysis to determine what it is. Most mucinous cystic neoplasms are surgically resected, but surveillance can be performed in selected patients. IPMNs with high-risk features should be considered for surgical resection, and those with worrisome features warrant a close clinical follow-up and shared decision-making. The majority of pancreatic cysts that undergo surgical resection do not harbor high-grade dysplasia or cancer, and this reflects the need to develop novel biomarkers and novel imaging modalities that are needed to improve our case selection for surgery. And with that, I would be happy to take any questions. Thank you.
Thank you, Shounak. This was indeed a very excellent summary, very practical as well with a review of literature. I did receive some private questions, and I do have one for you. So the tricky part, and from your experience, because you guys have a high volume center, the cystic lesions that are asymptomatic and they're borderline in size, so less than 2 centimeters in a 50-year-old man or a 40-year-old woman, what's your follow-up plan like? What's your next time that you can tell the patients, and you and the radiologist and the patient together, what would you pick as a timeline?
Yeah, so if it's a younger individual and it's a smaller lesion, then in most cases it is, initially at least, it is okay to follow them with surveillance imaging. And again, depending on the size of the cyst and whether there are worrisome features or not, the consensus guidelines actually spell it out fairly clearly. If you use cyst size in the absence of worrisome features, the surveillance interval can be anywhere between 3 to 12 months, and the interval is shorter with larger cyst size. Now, the other practical problem that comes up in practice is, if you have somebody who's younger and who has worrisome features, or maybe a cyst that's over 3 centimeters in size, should you do surveillance or should you do surgery? And there, often these patients, especially if the lesion is in the tail of the pancreas, where a distal pancreatectomy would be the solution, then oftentimes these patients, especially with unilocular tail cysts, will end up opting to go down the surgical path. But a smaller lesion, no worrisome features, head of the pancreas, we're thinking about a Whipple, those are clearly patients we need to do surveillance on to get a sense of how this is progressing. The other thing that I use quite frequently in my practice is to ask if they've had scans in the past. And when we are seeing these patients for the first time, a significant number of them will have had a scan in the past for something completely unrelated. And that can really give us a sense of the timeline somewhat retrospectively.
Yeah, no, thank you. Dr. Turkis, I had a question for you from the audience that asked about what's the best imaging modality to reassess pancreas cancer after neoadjuvant chemotherapy. Sounds like there is a frequent ask to perform EUS to reassess it. And what's your experience? In which population do you find that helpful?
The answer depends on what the ordering physician is looking for. If it is a surgeon, they usually look for, is there a progression of the disease despite the neoadjuvant chemotherapy or not? And that can be easily detected by CT. And then if the question is, what is happening to the viability of the tumor, then you need to do a functional imaging. And it will be better to use MRI with diffusion-weighted imaging or MRI with dynamic contrast enhanced sequence to detect the vascular changes within the tissue. Or you can do a PET. Unfortunately, PET is so expensive. You can only do 5 PETs in one patient if patient had a pancreatic cancer in the lifetime. So PET is unfortunately cannot be performed every year for surveillance purposes. So at IU, usually we get the request from surgeons, and surgeons want to know one thing: is the tumor stable during the neoadjuvant chemotherapy? Because if it is not responding and if it is spreading or growing in size, that means the chemotherapy is not working. But if the tumor is stable in size and they know that the chemotherapy is working, and it doesn't necessarily mean that tumor should shrink. The pancreatic cancer doesn't usually shrink because it has a lot of stromal tissue. That stromal tissue remains. And just because we call it stable in size doesn't mean that it's not responding. So this kind of information is what surgeons are needing from us. Therefore, they are ordering multiphasic CT. And oftentimes they are basically waiting for the surgery and after getting the benefit from the neoadjuvant chemotherapy.
Yeah, so it helps guide their next steps of therapy. Can you comment, you mentioned all the benefits of secretin, and especially in the pediatric population, the congenital anomalies of the pancreas are a frequent presentation, whether it's for obstruction or pancreatitis risks. And we find the secretin sometimes not adding benefit if the duct is already dilated from chronic calcific changes or whatnot. However, the smaller the child, and I'm very interested to hear from you, your comment in the adult as well population, we found that if we are looking for a workup for acute recurrent pancreatitis or a problem, that the secretin does add value with showing the smaller, more subtle problems. For instance, I could start with divisum, annular pancreas, and so on. And I want to hear from your table and studies where you showed the benefits that the secretin adds, even in the workup of neoplasms. When would you tell your team to, okay, order it without secretin, the MRCP?
Okay, I was expecting the opposite question, but you ran not to order secretin.
Yeah, when? I mean, I always get that question from the whole hospital. They call me and they say, do you really want it with secretin or not? And I usually say yes, because of the reasons that I mentioned to you. So I'm biased because I'm dealing with pediatrics. So I want to hear from you guys both from the adult standpoint. Is there a time where you say, fine, you're going to detect what you want if it's a new first-time MRCP for a condition without secretin?
Right, so indications for secretin is not many. Mainly you listed a better depiction of the pancreatic duct. Are you suspecting a pancreatic ductal variant, such as pancreas divisum, APBG, or other anomaly? Then you should probably give secretin. Second, are you suspecting a side branch IPMN? And we can see the connecting duct better with the secretin. Oftentimes it is hard to see the tiny little sub-millimetric size duct unless you give secretin. And the third indication will be, are you suspecting early chronic pancreatitis in this young patient? And as you know, the diagnosis of chronic pancreatitis is still done by the ductal criteria. If patient has 3 ectatic side branches, that is considered mild chronic pancreatitis. And those visualization of those 3 tiny ducts may not be easy without secretin. If you give secretin, then the ducts become a lot more enhanced and you can diagnose the early chronic pancreatitis earlier maybe. These are the most, in my opinion, 3 most common reasons that we should use secretin. Of course, if patient had Whipple, then you look at the anastomotic, the patency with secretin as well, because you look for the pancreas to secrete fluid after that. And then there are several other less important indications for secretin. I would like to do more and more with secretin because it helps me, but unfortunately it is expensive and it almost doubles the cost of MRCP. So we should consider that as well.
Yeah, so I would just add to that, the most common clinical scenario where I'm asking for a secretin MRCP in my adult population is in the post-Whipple pancreatitis population, because oftentimes it's a pancreatic jejunostomy site stricture, and endoscopic intervention on that site is technically challenging. It either requires a long limb ERCP or some kind of a rendezvous procedure through the pancreas, which comes with its own set of problems. So having a dynamic exam that really shows that, whether there's an obstruction at that site can guide decision making. Because some of these patients will not improve with a placement of a pancreatic duct stent because the pancreatitis was for something else. So I think in the post-Whipple setting and in the idiopathic recurrent acute pancreatitis setting, where we are looking for an abnormal pancreatic biliary junction or something that was not readily visible on previous imaging, I think are the 2 most common clinical scenarios where I use this.
Yeah, that sounds great. And I know with the cost and the extra time in MRI, and we have to be cognizant of that, but you're right, when we're searching for answers, those few kind of steps would add a lot of answers. So, well, thank you both for a great evening, very enlightening with pancreas knowledge. I hope all of our audience has benefited the way I did and learned a lot from our fantastic speakers this evening. And I encourage you all to call next week on August 20th, next Thursday, to hear also 2 fantastic talks on overview of acute pancreatitis and the surgical therapies. So with that, we would end, and these will be archived on our website. Thank you all for listening and calling on, and stay safe. Bye-bye.
Bye.